with focus on caregiver mental health and parenting support and responding in humanitarian emergencies. She holds a PhD and master's in clinical psychology and previously worked with War Child on mental health programs for children and families affected by conflict. Dr. Eve Puffer is a global mental health researcher and licensed clinical psychologist, and the Pamela and Jack Egan Associate Professor at Duke University and the founding director of the Duke Center for Global Mental Health. Her research focuses on developing and evaluating community-based interventions to promote child mental health and improve parenting and family functioning, including in Kenya, the Thailand-Myanmar border, and low-resource communities in the United States. Before joining Duke, Dr. Puffer was a research advisor at the International Rescue Committee. Sydney Tucker is a DPhil student in social intervention and policy evaluation at the University of Oxford and the Chief of Research and Evaluation for the Global Hope Groups Collaborative. Her research focuses on innovative approaches to evaluate the impact of interventions to improve mental health and protect children in crisis settings globally. She holds a Master's of Public Health in Epidemiology and Biostatistics and has led studies across the Middle East, North Africa, and Europe in complex crisis settings. Nicole Baldonado is a trauma-certified social worker specializing in capacity building and the design and implementation of psychosocial support for caregivers and prevention of violence against children in humanitarian crises. As the Director of Programming for the Global Hope Groups Collaborative, she has worked with international stakeholders to co-create, adapt, and implement evidence-based strategies for family strengthening across various crises. And Nisreen Hawatmeh is the founder and managing director of Sanadak Orphan Ministry, dedicated to serving orphans and vulnerable children through holistic trauma-informed care. She serves as project director of Hope Groups Jordan, providing psychological and emotional support to individuals and families affected by trauma and displacement. Welcome to all of our speakers. And before I hand it over to Felicity, a few housekeeping items. We will go through all of the presentations first and leave time for questions at the end. Please feel free to put any questions in the Q&A box at any time, and our presenters will try their best to respond. And we'll also have Q&A at the end of all the presentations. With that, I'll pass it on to Felicity Brown from UNICEF to provide us with a global framing of parenting and psychosocial support in crisis settings. Thank you, Felicity.
Thanks so much, Amanda, and thanks so much for everyone for having me here today. So as Amanda said, I'm going to do my best to give a very brief framing of the issue before we dive into some wonderful examples. Next slide, please, Amanda. So the need for mental health and psychosocial support, which I'm going to refer to as MHPSS, along with parenting support in emergencies in today's world, is immense. As of the end of 2024, there were 123 million people forcibly displaced globally. 40% of these were children and 73% living in lower middle income countries, where we know that resources are already limited. On top of this, many more live in contexts with active crises. So with escalating rates of conflicts and climate and ecological crises, children are facing vast and increasing threats to their survival, development, and mental health and social well-being. Next slide, please. In humanitarian crises, children are at increased risk of a range of detrimental outcomes in mental health and development. So some estimates suggest that up to 50% of forcibly displaced children will experience mental health difficulties. That's 4 times the global prevalence. While this figure is alarming, it's also important to note that 50% of children will not develop these difficulties, meaning that these outcomes are not inevitable. So this highlights the importance of building appropriate systems and appropriate supports for children and their families. Taking a socio-ecological approach, we know that children are deeply affected by the environments and systems in which they live, play, and grow. The family environment is absolutely essential, with caregivers being the primary, most significant and consistent agents in a child's development and well-being, even more so in emergencies. At the same time, we know that parenting practices and beliefs are influenced by the broader community environments and societal structures and systems that promote or hinder their ability to thrive. We know that crises disrupt children and their parents' access to education, community safety and cohesion, health and mental health care, and the ability to meet their basic needs. Displaced families can also face discrimination, stigma, and exclusion. Next slide, please. So we know that all of these factors place immense strain on caregivers. More than 1 in 5 conflict-affected adults experience mental health difficulties. And there is strong evidence that poor caregiver mental health directly impacts their ability to provide warm, responsive care and can increase their use of harsh parenting practices. This in turn impacts on children's well-being in many ways. So just to stress this point, let's look at these 5 components needed for children to thrive, as outlined in UNICEF and Partners' Nurturing Care Framework. We can easily imagine how the emotional and mental strain that comes along with exposure to crises impacts caregivers' ability to provide responsive caregiving, opportunities for learning, security and safety, and ensure good health and good nutrition for their children. Next slide, please. So what do we already know about supporting parents in crises? Well, in recent years, there has been a promising increase in research in this area. We see mounting evidence that parenting programs, including those delivered in humanitarian crises, may improve child mental health and well-being, parenting practices, caregiver mental health and well-being, and when they take a gender transformative approach, they also have the potential to reduce both violence against children and violence against women. But generally, we see small effects on caregiver mental health, and some analyses show that parenting programs tend to spend limited time focusing on parents' own well-being. So overall, we see that there is a great need for better data on a broader range of caregiver outcomes in crises, including their own subjective well-being, relationship quality, and exposure to violence. So if we're serious about improving the lives of children, we really need to look at how best we nurture caregivers as well. Next slide, please. To help guide our programming for parents, we can turn to the Global Parenting Support Framework, which was recently published by UNICEF and other partners in the global initiative to support parents. At the center of the framework here, you can see the parenting support pyramid. It has three levels of programs. So universal support at the bottom includes broad population-based initiatives that reach every caregiver in an aim to strengthen positive norms and nurturing practices, self-care, and preventing violence. For some caregivers, this universal support will not be enough. So the next level up, targeted parenting support, complements these universal services by addressing specific risks and challenges faced by families. And then at the top, a smaller number of caregivers may need individualized and intensive support, typically involving multiple professionals and multiple sectors. So the pyramid here recognizes that all caregivers will need some support and that some caregivers need a lot more. At the same time, the same family may need different supports at different times across their parenting journey. Therefore, tiered support options must be available. Parenting support can only achieve lasting impact when it's embedded within strong systems and enabling environments that support parents. So all of these aspects are essential in humanitarian crises as well. And Amanda, if you can just click, yeah. So in crisis settings, especially when taking a psychosocial lens, to avoid doing harm, programs must focus on promoting dignity and building on existing strengths. Our programmatic design must be deeply rooted in the context and culture, which can only be achieved through meaningful participation of affected communities. In emergencies, access is often severely constrained, so consideration of delivery platforms is essential in service design, and this also leads to the increased need for collaboration across sectors. Support for the workforce becomes even more essential as the workforce is often living the same reality of those that they are supporting. And finally, continued work is needed to continue to build the evidence base of what works, both in terms of content and in terms of implementation strategies in complex settings. So next slide. And how can we plan and implement integrated parenting and MHPSS support in emergencies? Well, when an emergency happens, we don't need to start from scratch each time. We already have knowledge and evidence from past emergencies that can help prioritize key activities that we need to do. So the Interagency Standing Committee has published the MHPSS Minimum Services Package, which I'm going to refer to as MSP for short, which highlights 22 high priority activities that should be implemented in all emergencies. These span MHPSS programs across the life course and include caregiver support activities. A key strength here is that this package is intersectoral, so it's bringing together different activities that are typically delivered by different actors across health, protection, education, and other sectors to provide one core response package. So next slide, please. I really encourage you to check out the MSP online to learn more because this could fill a whole webinar in itself. But I just want to quickly mention that it includes a range of activities with associated guidance and tools, including activities related to assessments, coordination, and monitoring and evaluation. But I'm going to focus on this set of 15 specific program activities, which include parenting support, and they include parenting support as part of an integrated MHPSS response. I'll briefly highlight some of these with examples. So next slide, please. First, we can look at workforce strengthening and the MSP activity here, which is to orient frontline workers and community members with basic psychosocial skills. So UNICEF has developed the Pocket Guide for foundational helping skills to support children and caregivers in emergencies. This is a practical and brief guide that has been used by partners in Gaza and is currently undergoing publication and will be available to share soon. Next slide, please. Next, and aligning with the universal level of the parenting support pyramid, we have the dissemination of key messages to promote mental health. As part of the MSP, a key message bank has been developed and in collaboration with GPI and other partners. In Gaza, deep contextualization of these messages was carried out with local teams to reflect the reality and needs of parents there. Next slide, please. So moving up to the targeted parenting support and linking to several of the MSP activities related to MHPSS support for children and their caregivers, we can look to some UNICEF programming in Syria. So the SAWA program, or Together in English, is a group-based MHPSS program for children aged 7 to 12, which is coupled with the Sanadi, My Rock, or My Foundation, and group-based MHPSS program for caregivers of children aged 0 to 12. So both were developed through collaborations with ministries, local partners, and communities, and they've been implemented across all 14 governorates of Syria. Preliminary pre- and post-analyses are showing that these programs are leading to improvements in child well-being, caregiving, and caregiver mental health. Next slide, please. And finally, and building from the Sanadi program, but aiming for a higher level of support, the Parenting in Between program was recently developed in Gaza to respond to the expressed needs from parents for support in managing the balance between how they want to parent with what is realistic and what is possible within their current capabilities in the current circumstances. So it has supplementary sessions diving into specific considerations for caregivers hosting unaccompanied or separated children, which is unfortunately very common at this time. So with partners, UNICEF has set up strong data monitoring systems and awaiting the clearer results of the program. Next slide, please. And just something to leave us with, I would like to highlight just how powerful the presence of a supportive and responsive caregiver can be for children, even in the midst of a crisis. So this is a quote from a child in Gaza who is mentioning, "The thing that makes me feel most important is when I'm tired, my grandmother stays by my side and takes care of me. When I'm scared, she hugs me. Even though my father is in the north, I feel okay as long as my grandmother is here." Next slide, please. And one final note before we move into the fantastic examples we have coming up, I just want to take a moment to acknowledge what MHPSS and parenting support are not, so what they cannot do. And this seems particularly important to note in today's changing world. So these programs are not a substitute for peace, and they're not a substitute for civil, political, economic, social, and cultural rights. So social and structural determinants of mental health, like violence, poverty, discrimination, require holistic and integrated service and policy solutions. MHPSS is not about helping caregivers and children tolerate the intolerable. So while these programs are undoubtedly providing an essential lifeline for parents in crises, they must be coupled with broader advocacy and efforts to reduce the root causes further upstream. So I'd just like us all to keep this in mind as we continue our important work in this space. Back to you, Amanda.
Great. Thank you so much, Felicity, for that excellent overview of global efforts to support children and caregivers affected by crises. I'll now hand it over to Dr. Eve Puffer to talk about our work on the Thailand-Myanmar border.
Thank you, Felicity, and thank you, Amanda. I am delighted to be here to represent our team, which includes Amanda as co-PI of this work related to our work on parenting along the Thailand and Myanmar border. Next slide. We know that families who are living along the border have high levels of trauma and daily adversity before, during, and after displacement. 44% in our work have been forced to hide or flee their home, 78% undocumented, and the majority experiencing food insecurity. We also found high levels of psychological distress and violence against children, which is consistent with previous work as well. The majority of caregivers reporting hopelessness, over half meeting the clinical cutoffs for depression or anxiety, and 68% of children experiencing some form of physical punishment just in the last 30 days. Next slide. So what we aim to do in this project is to move towards an integrated parenting and mental health and psychosocial support system. So we'll talk about a universal prevention program, which was a film called Being Family, an entertainment education approach. And the aim of this universal prevention is to have population level reach and impact. And then we'll talk about one of these more targeted approaches, as Felicity just showed. And in this case, it is a trauma-informed parenting and mental health program for groups of parents and caregivers that are at higher risk. And this, of course, is all in interaction with the crisis response systems in the context. Next slide. We had several phases of this project, and we're going to start with that bottom level of the pyramid with the Being Family film. We started this process of universal prevention research with formative qualitative work, interviews and focus groups with caregivers and youth as well. We then moved on to work with Serpanya Foundation on collaboratively developing the script for the film. Then into film production, and then finally into community film screenings. And on this next slide, you can see pictures from the production. The production was led by Serpanya Foundation, and we collaborated to integrate the formative research findings with what we already know from evidence-based intervention, and of course with the incredible collaborative and creative process from Serpanya. And all of the cast and the crew to produce this film were members of the refugee and migrant communities. The community screenings were then done through mobile cinemas in 22 communities. Entire families are invited to these screenings together. And after the film, which is about 66 minutes long, there's a 30-minute facilitated discussion about the key messages, one closing 5-minute video about those messages, and a take-home poster, which we'll show you in a moment. But first, we want to show you just a 1-minute clip of the film, Being Family. And this film follows two families, one that's struggling a lot, and another family that's struggling with some of the same stressors, but identifying some effective ways to cope. So the film follows these two families and follows how they interact and how they support each other. So you can see here, we can go ahead and play it, Amanda. There are English subtitles to help those of us who don't speak Burmese, but you can see here the father playing with his children and the father who's walking by, and that child is from the other family that is featured in the film. We'll just watch a minute together. Right, Amanda, I think we can stop there, this father is sharing with the other father some about his past and how he might want things to be different for his family moving forward. The next slide, Amanda, shows the handout that we give at the end that covers some of the key skills and messages that are shown in the film. And the left is the poster used for publicity of the film. Next slide. We conducted a cluster randomized controlled trial with about 2,200 caregivers. 22 communities were randomized to receive the film screenings, and 22 were in the control group. And results showed that there were positive intervention effects on parenting knowledge and positive parenting at both of our time points. We showed smaller effects on caregiver engagement and early learning, family functioning, and social support. And for one of our most primary outcomes, we found positive effects on reductions in physical violence against children, as well as on the belief about whether or not harsh punishment is needed in order to help children to grow up well. We didn't find meaningful differences on psychological violence or some of our other secondary mental health outcomes. Looking across all of this, we're very encouraged to see that such a short, light touch intervention at a population level could have positive effects on these primary outcomes of physical violence and positive parenting. Next slide. We'll then move on to tell you a little bit about our work for the selective or indicated prevention program, which were the smaller parenting groups for parents at higher risk. On the next slide, you can see our timeline and that we were developing this intervention as we were finishing the cluster randomized controlled trial of the film. Next slide, you can see the process that we went through that integrated participatory methods to develop the actual content of the parenting groups. This included stakeholder workshops, community stakeholders that included people from the communities. This integrated people who have been working on the border to support families in many different ways so that we could feel more confident that we were filling a gap and providing a service that was needed and not duplicating what people were already doing. We had mock sessions to get more iterative live feedback, and then we did a pilot with the final version with families before we started our trial. The next slide just shows some of those co-design teams when we were able to get people together to really have in-depth discussions about the manuals before they were finalized. This whole project resulted in an intervention named Parenting for Resilience. This is an intervention that includes 6 group sessions, and every session integrates parenting skills alongside mental health coping skills. The content puts a strong emphasis on how you can use these skills in conjunction with one another. And it's designed to be delivered by non-specialists from the community. On the right, you'll see the journey map, which was one of the key handouts from the manual that shows as the journey goes how you're building those mental health and parenting skills. On the next slide, we show you in a way that's a bit easier to see the parenting skills that are core components of evidence-based parenting programs in the green boxes. That will look familiar to many of you. And then in the blue boxes, the mental health coping skills that are layered on top: psychoeducation, relaxation, strategies from acceptance and commitment therapy, self-compassion, social support. And then the yellow boxes are the content that really links together some of those parenting and mental health skills and really spans both of those areas. So next slide, if you imagine these sessions, it's a combination of psychoeducation, a lot of very active skills demonstration and practice in the moment. And then we develop some multimedia learning materials that are shown throughout the session. Parents watch the film in its entirety as part of session 1. And then briefer clips of the film are used throughout as examples of use of coping skills in real life situations. In addition to that, we worked with Serpenya to develop new facilitation and animated videos for psychoeducation and skills building. So we're going to show you two little pieces of one of those videos from one of the most complex skills. So Amanda, we can go ahead and start at the beginning. This is all in Burmese, and this is about unhooking. So we'll just watch a few seconds. All right. So these animations, this is kind of representative of, first of all, introducing the skill, talking about the purpose of the skill, and then she will spend some time going through the steps of the skill. And then we can move, I think, to the 3-minute, 20-second mark, Amanda, and you can see how these develop to use extra graphics and animations to illustrate the most complex parts. You could go ahead. Okay, thanks, Amanda. And you can see what an excellent job Serpenya did of taking this content and trying to make it visually supported in terms of simplifying and streamlining these skills, which are complicated for all of us. The next slide. We conducted an individual level randomized controlled trial with recruitment by community volunteers instructed to identify caregivers at higher levels of risk. 477 caregivers participated with community facilitators and organization staff facilitators partnering together with 3 assessment time points. And our results showed that we had positive effects of this intervention on parenting knowledge, emotion regulation, and psychological flexibility, which is a mental health construct that was something that was specifically targeted by our coping strategies. And also engagement in children's early learning, positive parenting, the well-being of caregivers, and family functioning. We saw here decreases in the use of both physical violence and emotional violence in this higher risk group, a reduction in the belief of the need for harsh punishment, psychological distress, and post-traumatic stress, with the bold significant at both of our follow-up time points. And the ones in blue showing what we can think of as sleeper effects that actually weren't seen immediately, but were at 6 months. And we can talk a bit about that if you're interested. Our qualitative findings supported these results, and caregivers were able to help us understand the mechanisms of change and how they were combining these skills. So the first one talking about controlling their mind, which then allows them to speak more gently to children. And the second caregiver, in the latter part of the quote, really referring to unhooking about having a heavy mind, putting these thoughts on the cloud, and then letting them go. So we were hearing caregivers show that they were able to do this. Overall, we're seeing that entertainment education does seem to be able to reduce violence against children, and that this approach has potential for low-cost population impact at scale. And if, as Felicity was saying, we treat the caregiver's mental health alongside parenting, we can see violence outcomes. And we can see throughout that our success in this project was driven by community co-creation and strong partnerships. So in the future, we hope to think about scale up on the border and think about implementing this package together and explore adaptations across contexts. And for those of you on the call, we welcome opportunities for partnership and collaboration as we think through these next steps. We would love to partner with you all. So we are grateful to our partners, the team and the families who participated in our study, and then also the funders that made this project possible. Thank you all very much. Amanda, I'll pass it back to you.
Thank you so much, Eve, for that wonderful overview of our work on the Thailand-Myanmar border. I'll now hand it over to the team from Hope Groups, who will talk about their work in Ukraine and Jordan.
Hi, everyone. Thank you so much for being here. And we're going to share now about a program called Hope Groups, which aims to build hope in caregivers and protect children amidst war and displacement. And we'll share both about a program and evaluation in Ukraine and then also in Jordan. And we'll start with Ukraine, and we'll have Nicole sharing with us about the context and the development of the Hope Groups intervention. Over to you, Nicole.
Thank you, Sydney. We can go to the next slide. I'd like to draw your attention to the photos at the bottom of this page and just share that these were taken 2 days ago. The one on the left was taken 2 days ago in the city where 2 of my sons were born and where my 2 young nephews still live today. And I share that to bring relevance to this topic today, that the war in Ukraine, which started in 2014, is continuing today at full scale. A third of the population has been displaced. More than 10 million people are in humanitarian need, and there are rising mental health problems, family breakdown, and violence against women and children as a result of the war. Amidst these types of intense survival and humanitarian needs, a group of Ukrainian caregivers early in 2022 collaborated with Ukrainian and global subject matter experts to co-create Hope Groups to provide mental health and parenting support and prevention of violence against children amidst war. They identified 3 key needs, being mental health, parenting in crisis skills, and supportive social network. And they were decided to be named Hope Groups by one of the Ukrainian experts. Next slide, please. These are a 12-session support group of 5 to 10 caregivers led by peer facilitators from the trusted networks. And we have used implementation formats that are flexible between in-person, virtual, and hybrid. Next slide, please. And here you can see the content of the Hope Groups, which fall under the categories of providing mental health care and psychosocial support first for caregivers as individuals, then helping them to develop stronger relationships and communication with their children in crisis, and then work through crisis-related topics such as secondary trauma, loss and grief, and so on. And then finally, we discuss resilience at the end of this curriculum. So now I'll turn it over to Sydney.
Thank you so much, Nicole. So I'll share now about how we evaluated the Hope Groups among Ukrainians affected by war. If it goes to the next slide, please, Amanda. So we first did a pre-post study to just try to begin understanding if the intervention was feasible, if it was acceptable, and if there seemed to be effectiveness. And what you can see here, sorry, the figure is very small, but essentially everything we measured that was positive went up after people participated in Hope Groups, and everything we measured that was negative went down after people participated in Hope Groups. So we saw improvements across caregiver mental health, parenting practices, and reductions in things like violence against children and child behavioral issues. And this was happening beginning first in Poland and Ukraine, and then spreading throughout countries as Ukrainians were displaced and continuing to participate in the program. And this really paved the way for the decision to evaluate the Hope Groups more rigorously with a randomized controlled trial. Next slide, please, Amanda. Thank you. So I won't go into all the details of this, but what I want to emphasize is that we spent a lot of time thinking about how to do the trial in a way that would give rigorous results, but would also be feasible in the middle of a crisis setting. So there were 4 main decisions related to the trial design that tried to honor both of these simultaneously. So first, we decided that participants would be recruited through trusted, community-based networks. So there were facilitators who recruited within their own networks of shelters, neighborhoods, churches, NGOs, FBOs. And without having the trust of people in these communities, there would have been no way to recruit participants. So a huge thank you to everyone who was involved. And then secondly, our actual unit of randomization was the group of 5 to 10 participants who would join a Hope Group together. And the important thing about this is it enabled people who were from the same networks, the same families or churches or camps to participate in the Hope Group together. And then thirdly, our randomization was stratified by facilitator, which I won't go into the details of that, but this was really crucial for letting people participate in the program with the facilitator from their network, while also balancing confounders that could have biased the results. And lastly, as Nicole mentioned, we kept a flexible delivery format throughout the trial. This means that people could participate in the program in person, or they could join through video telegram calls and meet virtually, or they could do a mix of these two things and have a hybrid format. Similarly, there was flexibility with the frequency. So some groups met 3 times per week, some met 2 times per week, and some met once per week. But it's this flexibility that we think enabled the program to be feasible to have high completion rates at the end. Next slide, please, Amanda. So I'll just quickly show our trial flowchart. You can see people were randomized either to participate immediately or be on a wait list. Next slide, please, Amanda. And before I go on to the results, I'll just mention that our primary model was a 2-level generalized linear mixed effects model, and our aim was to estimate the effects of hope groups post-intervention between the intervention and control arm. Next slide, please. So one thing to highlight is that 98% of participants completed an inline survey, and this is really high, especially in a crisis setting. And we think this really speaks to the power of implementing through trusted community-based networks. And as you can see in the map here, there were participants from all over Ukraine and also outside of Ukraine, especially in Poland. And I have some percentages here. It was 29% of participants were externally displaced, 27% internally displaced, and 43% at home in war affected Ukraine. And for the most part, people were in their 30s or 40s, and majority female, although we did have about 9% male participants. Next slide, please. So now to go on to share the results, you can keep going, Amanda. So these are our primary outcomes of caregiver depression and anxiety, violence against children, and parenting practices. And you see that all of them significantly improved. And if you go on to the next slide, I'll display both our primary outcomes and our secondary outcomes together. I think it helps to see them to get a full picture. So if you go to the next slide, Amanda, thank you. Sorry, so many slides. I put brackets around the outcomes that relate to caregiver mental health and well-being. So you see that caregiver depression and anxiety decreased by 57%. Caregiver hope and resilience increased by 65%, and caregiver self-care increased by about 85%. So we were really encouraged and amazed that even in the middle of an ongoing war, people's mental health and well-being really can improve. If you can go to the next slide, please, Amanda. So we also have here violence against children and child behavioral issues, which you can see both of these decreased by over 50%. And then finally, the next slide, we have some parenting outcomes, which you see all of these improved. So we measured parental monitoring, positive parenting, nonviolent discipline, and parental involvement, which improved ranging between 25% and 45%. And then lastly, we have outcomes related to prevention of violence against women, which both improved by over 60%. And future work will try to build more on these types of outcomes to really understand how to protect and prevent violence against women in war and crisis. Next slide, please. So there's a preprint on Lancet Regional Health if you want more details of the study, and stay tuned for publication to follow. And then finally, if you'll go to the next slide, I just want to mention all of us are likely well aware of these often long gaps between research and practice. And our team has really been committed to trying to shorten these lags. And a special thank you to Dr. Susan Hillis, who I think is on with us, who's really led this kind of thinking. And within 2 years of the initial Ukraine RCT results, there have been 6 Hope Groups adaptations with local partners in different regions and settings, which Nicole has really led. And it encourages me to think that our research really can have real-time impacts when we're partnering with implementers around the globe. So we'll go on now to hear about one of these adaptations in Jordan. And we have Nasreen with us to talk about the adaptation process in the local context in Jordan. Welcome, Nasreen.
Thank you so much, Sydney, and thank you everyone for being here today. It's an honor to share our work from Jordan. Next slide, please. Building on the Ukraine model, we adopted hobby groups for, not this slide, before, yeah. So building on the Ukraine model, we adopted hobby groups for the MENA region through a one-year process. We kept the core structure while aligning the content with cultural, social, and religious values. To understand why this adaptation is so critical, let me take you into the context where we implemented the program. Next, thank you. We worked in Jerash camp in Jordan, where families face long-term displacement and difficult living conditions. At baseline, the level of need was very high. 85% of parents had depressive symptoms, and 60% said that they felt better off dead. Children were also heavily affected. 82% experienced emotional abuse, 55% had depressive symptoms, and 30% said that they wished they were dead. These numbers show a clear and urgent need to support both caregivers and children. The participants were recruited directly from within the camp to ensure that the program remained community-based and accessible. Next, please. The vision of Hope Group was to create an environment where parents can build hope, improve their mental health, and learn positive parenting practices so that we can ultimately keep children safe and reduce violence and strengthen parent-child relationship to better protect children. Thank you so much.
Thank you so much, Nasreen. And I'll share now about how we evaluated the Hope Groups program in Jerash camp. Next slide, please, Amanda. So we thought a lot also about how to design this trial. And if anyone is working on randomized rollout trials, I would love to connect with you and talk about this. We decided to use a rollout trial for two main reasons. The first is it can be really feasible on the ground. So as you can imagine, this trial is 490 participants in total by the end. And that would be a lot for any implementer to begin all at once. So by using a randomized rollout trial, facilitators are able to implement Hope Groups at a capacity that's reasonable and do this over time to then reach more families. And the second benefit is it enables these sustainment periods that you see in blue. So we'll be able to also follow up with the early cohorts to see the long-term effects of the intervention. So ultimately, we'll have post-intervention effects, 6-month and 12-month follow-up effects. If you go to the next slide, please, Amanda. Today, I'm actually just sharing with you results from an interim analysis of the first 150 participants. And our team has used primarily Bayesian interim analyses to really try to understand in real time. First of all, is the intervention safe? Are there no harms? Second of all, does there seem to be benefits, which helps us both begin scaling and improving as needed and adapting for new settings. So next slide, please. So just to share, for the results I'll be sharing, as I mentioned, it's the first 150 participants, and it's about 80% female, and the average age is 45, and there's a high median number of children of about 5. Next slide, please. And as I mentioned, we've used these Bayesian interim analyses, and our primary outcomes for the Jordan Hope Groups project is mental health, specifically depression and anxiety, and violence against children. So to share with you the results, this is comparing control arm participants to intervention participants who just finished the intervention. And we saw that control participants had 1.85 times the rate of depression and anxiety compared to the intervention arm. This means that people who didn't participate in the program had 85% higher rates of depression and anxiety. And then secondly, in violence against children, we saw that control participants had 1.4 times the rate of violence against children compared to intervention participants, which again means that it was a 41% higher rate of violence against children among people who didn't participate in the program compared to people who did. So for us, when we were doing this evaluation, it was really important to know if this intervention would be similarly effective in a totally different context, both a different culture and a different context in terms of war and displacement. So we were really encouraged to see these results. And next slide, please. And a huge thank you to Nasreen and the local team who has really led us trying to think about the mechanisms of Hope Group's effectiveness. So these two quotes came from a day in Jarash camp when Nasreen had gathered participants to learn what their stories were and how the Hope Groups had benefited them. And one participant shared, "I healed and I created an environment of healing for my children. Our relationships have transformed and my children have come back to life." And this was actually a participant who had learned that her children had been sexually abused. She had also, through the program, learned how to talk with her children about what had happened and how for all of them to process the trauma, to grieve, and to move forward with hope and practical ways to keep children safe. And then secondly, there's this quote, "I experienced a place of love, comfort, support, and safety where I could share, grieve, and connect with others, which taught me to go home and create the same environment for my children." So what the stories have told us is there's something in the environment people experience in the program that equips them to go home and create the same environment for their children. Next slide, please. And finally, just to share about our future directions, as Felicity shared at the beginning, the need is massive and the need is growing globally. So our team is really committed to partnering with local partners throughout the globe who think Hope Groups could benefit the context where they're serving. And we're very committed to these 6 stages of adapting the program for new settings, training people, coaching people, evaluating the program together with these leaders, and advocating and scaling and sustaining the program long term. So I'll just mention a few places that we're focusing on right now. So we're aiming to do a long-term follow-up in Ukraine, and Nicole is also working a lot on scaling the program more broadly in Ukraine. And in Jordan, of course, we'll finish this RCT that we've shared about today and hope to scale more to new areas of Jordan and more within Jarash camp in Jordan. And in the US, we've just launched a pilot for refugees specifically. And in Sudan, we're about midway through an RCT also of a Hope Group's adapted version from Jordan for Sudan. And in Colombia, we've had an initial pilot with promising results and are doing a long-term follow-up there also. So lastly, I just want to say a huge thank you to all of our many partners. You can go to the next slide, Amanda, who've made this work possible. So we're so grateful for each of you and also for you all coming to listen. And lastly, I'll just mention all the Hope Group's content is open source and you can find it on the World Without Orphans website. Thank you all so much, and back to you, Amanda.
Great. Thank you so much to the Hope Groups team and to all of our fantastic speakers today. So now I think we can open it up to the audience for questions. And I do see some questions here in the chat, and I think some of them have been responded to already. I'm wondering if any of the audience members, if you feel free to raise a virtual hand if you want to answer a question. I'm sorry, to ask a question, or I can also read out any of the questions in the chat box. Just give it a minute to see if anyone raises their hand.
Hi, thank you very much for sharing your good work. It's really, really very encouraging and very important job that you did. My question is, like I understand that there was a parenting focus program, but did you have us like co program for the improving parents or the community mental health? Like what was the content? Like what did you do to improve their mental health so that it can channelize to children?
Eve or the Hope Group team, anybody want to respond to that?
I wasn't sure if that was specifically to us, but the question that I understood is what we did to address the mental health of the caregivers alongside the children. Yeah.
Yes.
Okay. Yeah, so in our program, it was all integrated together. So there was almost equal content for the parents' mental health and the child mental health. And so that included psychoeducation about thoughts and emotions, some of the content from acceptance and commitment therapy is focused a lot on handling thoughts and emotions in situations where you have uncontrollable stressors. And so identifying what you're able to do in those situations and cope with those. So those were some of the strategies that we used. But if anyone from the Hope groups wants to add, that would be great.
I can just say, in addition to that, I think grounding and stabilization were really key for the crisis mental health, but then also informal supports. We've seen with the Hope groups for Ukraine specifically that many of the participants and facilitators maintain contact long after the program is over. And so that informal support really does help to benefit their mental health, not just during the program period, but also afterwards. So that's from Ukraine.
Okay, so what I understand is not everybody it's like cognitive focus, like identifying the thoughts and then to cope with that. But was there any emotion focus? Because there will be in that war situation, crisis situation, people are more about like more traumatized, emotion focused. Was there any program? Because not everybody is cognitively like not everybody's strength is cognition.
Right. I think Nisreen might be able to answer this, but I would just say, going back again to this idea of grounding and stabilization, which are not based on cognitive therapy, but really focusing more on just that stabilization within immediate crisis and trauma situations and dealing with triggers. And it's really more focused on regulating the nervous system. So Nisreen, I don't know if you want to add anything else.
Actually, we follow up after the sessions with each participant if there is a higher need than only being in a session and following up normally. We come alongside with the counselors, one-on-one counselors to follow up.
Great, thank you for that question.
Thank you.
We also have a question from Alejandro. Go ahead.
Hello, my name is Alejandro Gonzalez from Mexico. So I already sent my question, but I will do it. In settings where psychosocial and mental health care is essential for children and their caregivers, how can we effectively engage other health professionals involved in their care so that responsibility is shared rather than resting solely on mental health specialists? What strategies can be used to successfully raise awareness and foster meaningful multidisciplinary collaboration, and also with the people who at the end take the major decisions, like the administrators, directors, who at the end set the budget for psychosocial programs? Thank you.
I could answer the first part of that question. We've been having some conversations with our team about the scale up and how to integrate the health system more, how to integrate other services, and also for that crisis response, the top of the pyramid. And I would say that there's a lot of potential for psychoeducation for those providers to be able to screen for mental health services, but also to provide brief intervention. So many of these strategies that we focus today on community providers can also be provided to those who are seeing children and families in primary care. So I think it's an excellent question, and another area of task sharing that we didn't talk about today, but is really, really important, because in addition to the community, primary care is where a lot of the children and families will present first. If someone else would like to talk about the policy piece, that would be great as well.
One thing I was just going to mention, really more on the first part of your question too. None of us mentioned this in our presentation, but the Hope Group's facilitators are lay trained individuals, so they're not mental health professionals, and that was an intentional choice, just with the understanding that the massive mental health need will be more than what the professional workforce can address in crisis settings. And as Nasreen mentioned, and Jordan specifically, there were at times participants who needed more support than what the lay trained facilitator could provide. And so they would link them with a psychologist in those times. So I think those sorts of collaborations between trained professionals and lay trained individuals are really important, especially in crisis. Nasreen or Nicole, you may want to add to that also.
There is another question that's linked to the question that Alejandro had, and also Felicity, I think, really connected to, I think, the powerful statement that you ended your talk with around, what parenting and MHPSS support isn't. And it's this question by Ana Maria about how can parenting support be effectively integrated into core emergency services, for example, protection, nutrition, health, during the acute onset phase when it is often treated as secondary. I was wondering, Felicity, if you had any thoughts about that.
Yeah, and I think it's a really really key point. And I think in my opening I brushed over it really quickly, but I mentioned there the importance of intersectoral collaboration. So I guess this is touching on Alejandro and the second question as well. So I think both parenting and mental health being really intersectoral issues. They don't sit in one sector or the other. They're relevant across many sectors. This is both a challenge for coordination in emergencies, but also a great opportunity. So while we do see that these programs can be integrated into each sector and potentially, they're increasing access and increasing the number of families that we can reach when we work across sectors, it can also be a challenge in terms of the coordination efforts that are required to make sure that that happens, and that in each sector, mental health and parenting support are being prioritized. So there, I think this is something that the field needs to work on further in terms of that, the implementation and policy side of things in terms of scaling up these programs. And there is a recently, maybe not so recent now, but a published guide on MHPSS coordination in emergencies that does provide some guidance there that can be helpful as well.
Great. Thank you so much, Felicity. And we are at time. So I'd just like to first thank everybody who joined the webinar today and for all of the fantastic questions. I'm sorry if we were not able to get to all of your questions, but feel free to reach out to our speakers, and I'm sure they'd be happy to connect. And thank you to all the speakers and for everyone committed to and invested in supporting children and caregivers in crisis. Thank you for your participation.